Depression is a specific state of a mood, is a mental illness, which is defined by a set of index symptoms, and those are defined and summarized in the DSM or ICD, as I mentioned, and they reflect, especially the core of those symptoms is the mood level, is suicidality, is level of activity, and all of that. So depression is the most frequent and the most prevalent mental disorder. That's very important to understand. And there are different kinds of depression, so there are also different symptoms you have to look for or have to understand. And also, what is also important, if we start talking about symptoms, is that symptoms are heavily influenced by circumstances, by population, by culture, and whatever. So symptoms for a mood challenge or a depression in a, for instance, in an Islamic community will look different, or very often, to one in a Western community, or in an Indian community, and also gender differences. So that's important to keep in mind. Very often clients come to an emergency room or to see their family doctor, and the background may be a depression or depressive symptoms, but they talk about stomach pain or headache or sleeping disorders or something like that. So overall problems in functioning. So what you very often see in a depressed state in the beginnings are more general symptoms, like that the individuals have problems really to cope with their challenges, so they are not very active, they stay in bed very long, sometimes they stay in bed the whole day, they are, but on the other hand, they're not sleeping very well, it's not a refreshing sleep, a lot of them coming with sleep problems in the very beginning. So this is more a general sign, as you said, or a precursor, so where you need to think, okay, and then you ask them about, for instance, about their thoughts, about their overall mood, and then you find out that there is much more than just sleeping problems. So this is probably the typical situation in primary care. In emergency rooms or acute care, you very often find people coming to an emergency room with suicidal ideations. So they don't want to live anymore, or they don't be able to live anymore, or they want to kill themselves, different things like that, which are closely related to the mood challenges. So that's what we call suicidality, and which is also a very, very common, very important symptom and reason for people to reach out for help, for support and care. And so those symptoms have to carry on for some time. So otherwise you won't be diagnosed with a depression. So there is a time frame to that, and there are some what we call index symptoms or core symptoms of depression to make the diagnosis of a depression. So the interesting question is, for a family member or a friend or a peer, when to worry, when to really motivate your friend to go for help, to look for help. And I think very important is if things are persisting for more than 4 weeks, I would say. If the person is really suffering, so if the level of suffering is high, and especially if there are significant suicidal thoughts. So suicidal thoughts or suicidal ideations are very important to monitor, but they're more frequent than people think. It's not so unique. A lot of people with mood challenges are not talking about that, but they are existent. So, and that's an expression of very often of severe depressive thoughts, which is really worrisome and important to see as a critical hint to push people or take people even to a professional, is if people start planning their suicide. So it's what we call suicide plans. If they really think, okay, I want to jump from that bridge, or I'm gonna go for an overdose, or I'm taking those pills and I already have them in my apartment. So then it's really a time to contact a professional, or even to immediately act and go with them to see a psychiatrist. So that's very important to differentiate. The most important thing is to stay in touch with the person and try to attach to them, right? Because the most important therapeutic help is in such a situation is the relationship you are able to establish to a person and continue to hold to a person which is in a crisis. Okay, self-harm is a very general topic. It's a very general term. Well, in psychiatry and in diagnostics, it's most of the time very controlled pain you inflict on yourself. And that's very often an attitude or behavior young people are imposing on themselves to get rid of too much tension. It's not the intention to, they not intend to kill themselves, but they really systematically inflict pain, from cigarettes to cutting themselves. And the reason for that is that if they start bleeding, or if they feel the pain, they feel themselves. It's more connected to, let's say, very, very complicated developmental conditions young people are in. And it's also very often a symptom of what we call personality disorder in psychiatry, which is not a good term. And that's different. So suicidal ideations or self-harm impulses are a different set of symptoms. So if you were interested in really to understand the exact measurements and the classification, so mood disorders are well described and classified in the current classification system, in the DSM-5, which is in the United States classification system, APA, American Psychiatric Association, or the International Classification of Disease, which is organized and provided by the World Health Organization. And there is a family of instruments which is helping you to diagnose all kinds of mental conditions, including depression. and there are screening instruments, and there are detailed inventories you could go through, which are very often available on the web. And if someone is kind of in a situation of being depressed, then sometimes it's very helpful to use such a screening instrument, and if the screening is positive, then to do a detailed assessment, like with a back depression inventory or other gold standard instruments, to really know. Yeah, because depression is such a frequent condition, and also based on the symptoms, people with mood challenges are very often isolating themselves. They are hiding in their apartments, they withdraw from their social networks, so it's one of the most important pieces is to stay in contact with the individuals and to look after them, to actively approach them and not ignore them in their crisis, to look after them. So that's one part of the closer community. And for the bigger community, it's very important to really think about how you speak about depression, how you speak about mood challenges or anxiety or mental illness. We know that mental illnesses and mentally ill persons are very stigmatized, but if you think about that, some of the numbers are really high, that nearly in every family you have someone with a mental illness, and a mood disorder is the most frequent mental condition. It's very important to understand that this is not just a little tiny minority, that probably a lot of us, some point in their lives, who are going through a mood challenge or a depression. And it's very important that they feel accepted, that they're not stigmatized in the community, that there is help and there's a willingness to contact and to stay in touch with them. So to go through this crisis. And most of the individuals overcome their crisis in a short period of time and stay very functional members in the community. So from a big picture, really to reflect the attitude and avoid any stigmatization, and if you are able and willing to stay in touch with people which are in a critical situation. That's quite a broad question. So it's very interesting. So mental challenges are not really fitting into those small boxes, because no client who is coming into your door as a professional or into a clinic or to see a primary care physician or whoever normally comes with only one problem. They come with several problems. That's the reason psychiatry also decided to describe it really in detail and to get a better understanding of how things are interacting. So mood disorders and anxiety disorders are very often coming together. And mood disorders and substance use disorders are very often coming together. And it's very important to understand that, for instance, suicidal ideations and suicidal action are very heavily impacted by substance abuse and mood challenges as well. So there is a close entanglement of those. So because to give you a background, a lot of people, for instance, if they're depressed, they can't sleep. What they do, they start to take more than necessarily benzodiazepines, or they take sleeping pills. They drink alcohol. They do other drugs because it helps them to relax. And over a short period of time that works, and then it becomes an additional problem. And they become even depressed because they start to heavily use, and it becomes a vicious circle. And the point is, you need to help. You need to understand that functionality to help them appropriately, and you need to address both things and provide a better coping mechanism with their mood challenge than what they do in the first place. So they need to learn that too much alcohol actually is not really making them feel better, and very often, and on the long term for sure. And the same thing is with the traumatized group. A lot of people respond to traumatic experience with mood challenges, so with depression and anxiety. What we call this post-traumatic stress disorder is only one part of trauma-related response or trauma-related psychopathology. A lot of it's also general anxiety disorder or depression or sleep disorders. It's very close, and if you understand what actually is what is really bothering those patients or those individuals, then you are in a better position to help them. And there are two major strategies to do that, which are quite similar. So you offer them psychosocial help, and the core of that is what we call cognitive behavioral therapy, which is very helpful for all three, for trauma, for anxiety, and for mood disorder. And you could also offer them some antidepressants, which are for some also very helpful. And if it's more complicated, you do both. And that's the point where you need really professional advice and support. The majority of people recover very well. They have probably a period of depression. Could also be, for instance, be closely connected to a life event like divorce or a loss or something really which is critical for yourself, and then they recover and do well over the rest of their life. Then there are some people which are very sensitive and relapsing also in terms of depression and have an episode now and then. And a very small group actually is chronically depressed, so they are depressed all the time. So overall, if you get appropriate treatment, the chance to recover are good, even if you have a severe or major depression. Yes, I think it's really important to understand that how frequent that is, and also, let's say, not so severe levels of mood challenges or depression in the population are very often making it difficult even for young people to get the good grades and be successful for a time. And if you understand that, probably you're a little bit more tolerant, and that people need to deal with those symptoms before becoming really a full, powerful member of the academic community, for instance. And a second piece I would like to mention is depression is happening across the population, in all groups of the population, but it's more frequent among people which are socially marginalized and homeless and in a difficult situation overall, alone, without job. So there, the rates of depression are quite high. And third remark is, what I think is especially concerning is that the rate of suicide among young people is very high in Canada, especially among also First Nation kids, and we're not really responding to that. We don't have an early intervention approach. It very often takes a long time until there is any kind of help or professional support. And in a developmental stage, during adolescence and young adulthood, you're very sensitive towards all kinds of mental challenges, and mood challenges or depression are very significant. So that's a time also where you experiment with substances, and where you have all kinds of, you have probably your first sexual experience, you have all kinds of things you need to manage, school, transition to adulthood and all those things. And this is for some overwhelming, and that's a time where you need good advice and good help. So I think what I would like to see is more of a early intervention approach, so good counseling in schools, or really accessible advice and mentorship to help young people over a very sensitive period of their life.